Hello and welcome. I'm Heather Cronus-Danek, Senior Director of Development for Individual Giving for the Ioneer Foundation. Thank you so much for joining us for our bi-weekly webinar focusing on the sights and sounds of the Ioneer Foundation. Today's Sight and Sound Bites is age-related macular degeneration, understanding genetic and behavioral risk factors to develop new therapies. I'm so excited to welcome both a current faculty member to the Department of Ophthalmology, along with a new recruit. So we have John Ash, who is joining us for the first time. He is the Ronald Salvitti Professor of Ophthalmology Research, Vice Chair, Director of Research at the University of Pittsburgh School of Medicine. And we have Alexander Anetakis, who holds both an MD and an MBA. Dr. Anetakis has been a vital member of the Department of Ophthalmology for a long time. He is the Clinical Assistant Professor of Ophthalmology, Senior Advisor to UPMC Enterprises, Translational Sciences, and University of Pittsburgh School of Medicine. So before we start, a couple housekeeping tips. We ask that you mute. We ask, chatter has been disconnected. Please send questions in, but if possible, make them broad. Personal medical questions we will not be able to answer when you're on. And remember to follow the Ioneer Foundation. Our work supports the research of the Departments of Ophthalmology and Otolaryngology at the University of Pittsburgh School of Medicine. None of this happens without your support. So without you, we can't support our researchers. So I am honored to ask Dr. Alexander Anetakis to begin the presentation.
Thank you, Heather. All right, well, welcome all those on the line. Glad to have you here with us today. So Heather gave us a wonderful introduction, so I'm just going to jump right into giving a little bit of background on age-related macular degeneration, and then Dr. Ash is going to take us through his exciting research and where the field may be going in the near future. So the things I'd like to go through today, we're just a quick 101 on ophthalmology, just the structure and function of the eye to make sure we're all talking the same language and on the same page. And then we'll be going through non-exudative as well as exudative age-related macular degeneration, the two versions that you may have heard of, dry and wet as it's also referred to. We'll talk about current therapeutics out there right now. And then finally, I'll finish up with clinical trials that are out there. So again, looking at the anatomy of the eye, starting from the front to the back, you have the clear window of the cornea. Right behind that, you have the colored part of the iris. And behind that, we have the lens of the eye. When people will talk about cataracts, that's what they're referring to, the cloudiness of the natural lens that occurs with age. Behind that, the vitreous humor, and then finally the retina lining the back wall of the eye. The retina functions a lot like the film of the camera, and the eye does work a whole lot like a camera. And the very center of the retina is known as the macula, hence the term age-related macular degeneration. It is a disease of the entire retina, but primarily affects the macula. And the macula is a critical structure. It's what's involved with reading, driving, recognizing a face, watching a ball game. All the important things we think about vision really come from the macula. And then finally, we have the optic nerve connecting the eye back to the brain. And so again, just looking at the function of the eye, you have light entering the cornea, and both the cornea and the lens itself serve as refractive lenses. So the light is bent or refracted back to the retina, and it's focused to a single point on the macula, or even more specifically, the center called the fovea. From there, that light image is translated into electrical energy, and that electrical signal is transmitted to the brain via the optic nerve and allows us to have what we call vision. So talking specifically about age-related macular degeneration is a very large patient population size. Over 10 million patients in the United States alone have age-related macular degeneration. It affects approximately 1 in 8 patients over 60 years of age, and it's the most common cause of irreversible blindness in older persons in developed countries. And then in worldwide numbers, it's even more dramatic and more scary. Over 200 million people have that worldwide right now, and projected to be almost 300 million by 2040. So a bad problem that's continuing to grow, unfortunately. So what does a patient see when they have age-related macular degeneration? On the left side of the screen, you see the normal vision of what a patient would see looking at these two little boys. And on the right side of the screen, you see what happens in devastating end-stage age-related macular degeneration. They can lose most of their center vision as represented by that black scotoma, and then even the peripheral vision is somewhat affected there. You can see it's a bit blurred. I really like this slide a lot because it really takes you through the progression of from normal anatomy all the way to the more advanced versions of age-related macular degeneration. So focusing on the left side of the schematic, you've got the rods and cones that you may recall from your biology days back in high school. Those are really the workhorses of the retina. That's what takes the light and translates it into an electrical signal. And then right below that is the retinal pigment epithelial layer, or RPE for short. And that's a really critical layer of the retina. It does many different functions for the retina. But as I tell my patients, that nourishes the retina over top of it. It's kind of the most easiest way of explaining it. But one of the functions that also serves as is the garbage man of the retina, so to speak. And so as these rods and cones create waste products throughout the day, those waste products have to be carried away from the eye, and the RPE does that. When that process doesn't go smoothly, you have something known as drusen, as you see there towards the middle of the schematic, those yellow humps that you see there. Those are the buildup of the waste products that occur in age-related macular degeneration. And that's represented clinically what I see when I look at a patient. By the second photograph there on the bottom, you start seeing those hallmark of the disease, the drusen. As time goes on, those drusens start to coalesce, and as they coalesce, they form something known as geographic atrophy that you see as the third picture there. And unfortunately, once you reach that stage of disease, it's a rather severe scotoma or blank spot that those patients have, and they really are severely impacted in their visual function. Transitioning to the fourth picture there, you can see the red and the yellow there. That's blood and exudates building up in the retina from what we call neovascularization or choroidal neovascularization. One of the other functions of that RPE, that vital layer, is that it serves as a barrier between the retina and the layer below that called the choroid, which is a specialized blood vessel layer. When that barrier is intact, everything is fine. But in macular degeneration, that barrier can break down, allowing the choroidal vessels, the normal ones, to have access to the retinal surface and subretinal space, excuse me. And that's where those blood vessels can grow into there and break and bleed and leak and cause all kinds of havoc and can cause severe vision loss on the wet version of the disease there. So I put up this very busy slide for a reason. Not that we're going to walk through this in any way, shape, or form, of course. But looking at that flow chart on the left side of the screen, you see all the different things that are happening in age-related macular degeneration and all the different processes that are happening. And the reason I bring that up is I want patients to understand, and people that are listening to the webinar to understand how complex of a disease this is and why it's so hard to attack this problem. Because if you hit any one part of that pathway, there's other ways for the pathway to get around that, so to speak. And so that's why it's such a challenging disease to really attack and try to find a solution for. So talking about non-exudative first, the current therapeutic that's out there right now, there are two vitamin therapies out there. There's the AREDS formula and the AREDS 2 formula. AREDS is an acronym that stands for Age-Related Eye Disease Study that occurred in the late 90s going into the early 2000s. And that was a study to see if you gave a large vitamin dose to patients with macular degeneration, could you slow down the disease? Unfortunately, the answer is yes, and we'll get to the results here in just a second. But you have the original formula, and then there was a follow-up study known as the AREDS 2 study. And out of those two studies, we have these two formulations. The one formula there, the original one, you can see listed. And then the AREDS 2, the main difference there is they removed the beta-carotene and substituted lutein and zeaxanthin. And the reason that was done was that there is some evidence that beta-carotene causes an increased risk of lung cancer in our smokers. Being that smoking is a big risk factor for this disease, that affects a significant number of patients. And so the researchers wanted to come up with a formulation that did not have the beta-carotene and thus AREDS 2. There was some hope that potentially there would be a better effect as well, but unfortunately that was not the case as referenced here on this slide. So again, the AREDS 1 study was completed in 2001. It was over 3,600 patients. And what they were able to show is that they could reduce the chance of progression to advanced macular degeneration by about 25%. So maybe not quite as much as we had hoped, but it was something. Prior to that, we literally had nothing to offer to these patients. And then the AREDS 2 formulation was finalized in 2006, over 4,000 patients there. So very well done, very large studies that really strong scientific proof that these vitamins really do something. But unfortunately, the results were somewhat similar. It really wasn't anything more robust than what the original AREDS formulation could provide in terms of stopping progression of the disease. It does slow the disease, and that is still worthwhile doing. So again, another busy slide, but it's important to understand just how much research is out there and how many things are in clinical trials and the different ways that different companies are attacking this problem. There's people looking at neuroprotection, people that are trying to reduce the toxic byproducts, people that are actually changing the visual cycle by modulating that, people looking at stem cell therapies, and then probably the most common one, the one that's most robust, is looking at the inflammatory cascade, what's known as the complement cascade, that we know for sure plays a role in macular degeneration, and people are looking at ways of modulating that. And I call your attention to the two arrows there, APL2 and Zimura, which are the next two that we're going to talk about, because those are the most advanced therapeutics that are out there right now in terms of dry age-related macular degeneration, or non-exudative. So the first one to chat about is the APL2. It is a complement 3 inhibitor from a company known as Apellis. And this was in the current trials, in the phase 3 trials, they're looking either monthly or every other month intravitreal injections. So injections directly in the eye. And there's two different phase 3 trials. One is known as the OAKS and one is the Derby. In the OAKS, they were able to show a reduction in the geographic atrophy growth by 22% in the monthly injections and 16% in the every other month. So every other month did not do quite as well as the monthly did. In the second phase 3 trial, Derby, they showed a reduction in geographic atrophy, but not quite as robust, and that did not meet the primary endpoint. However, in their phase 2 trial, which preceded the phase 3 trial, they did show a similar reduction in geographic atrophy by 29 and 20% respectively, monthly versus every other month. And so on the backbone of those two, the one phase 3 and the one phase 2, they felt that they had enough to go to the FDA for approval. And they do have what's called a PDUFA date, which is basically the final meeting with the FDA, where they're going to find out what the answer is from the FDA at the end of this month. So in the very near future, we're going to have an answer whether or not this drug is going to be approved. Now, we'll call your attention to the exudative macular degeneration incidence in this trial. And the reason being is that it is almost maybe double and maybe even close to triple the incidence for the experimental arm. So the patients that were getting the active drug had a rate of either 6% or 4% chance of getting wet macular degeneration that they did not have prior to enrollment in the trial, versus about 2% in the patients that were getting the sham injection. And so that, as a retina specialist, is concerning to me, that I am solving one problem, or at least treating one problem, I should say, while creating a second problem. And that certainly gives me a moment of pause when I think about, I'm going to offer patients intravitreal injections monthly or every other month, and potentially give them another problem. Is that enough? I don't know, and we'll find out soon whether or not the FDA is even going to approve that. But as a retina specialist, it gives me a moment of pause about this drug. In a likewise fashion, Zimura from Iveric Bio, it also attacks the complement cascade, but in a slightly different way. These are monthly injections, and they looked at two different dosages. Similar reduction in geographic atrophy growth rate, but maybe a slightly more robust effect from this one. But on the wet macular degeneration instance is even more concerning. So almost 10% chance of getting wet macular degeneration in this trial versus 2.7% in the sham. So again, it's encouraging that maybe we're finding a way to modulate this disease, but it doesn't come without a cost. And that's a scary thing to our patients. And so it's something to be aware of as these trials come to completion. They are set to have their new drug application filing with the FDA at the end of Q1 of 2023. So hopefully by late 2023 or so, we should have an answer from this company as well. I'm going to shift gears here now to the wet macular degeneration side of it. Again, very large patient population, approximately 1.5 million in this country and approximately 30 million patients worldwide. Untreated, this disease leads to legal blindness in 95% of patients within 2 years. So very fast progression, very severe vision loss if untreated. Fortunately, nowadays, that's not necessarily the case. We do have these intravitreal injections that have really revolutionized how we treat these patients. I had a unique perspective on this when I was in training from 2004 to 2006, doing my retina fellowship. The first year of my fellowship was all a laser therapy that we'll talk about in a second. And the second year was all injections. And so I got to see how things evolved pretty quickly. And that was the time frame when Avastin, I'm going to use all the trade names here because they're easier to say than the generic names, but Avastin was a cancer therapeutic that there was a doctor who was brave enough and smart enough to figure out it could be used intravitreally in 2004. And now it's been used all across the world by retina specialists for the past 15, 16 years with great success. It really has changed the disease quite a bit. A cousin to that drug is known as Lucentis. That was FDA approved for this use in 2006. And there's been a couple more since then. Eylea, Beovu, and Vabysmo was the most recent one in 2022 that just came out this year. And we're excited about that one because we think the length of action for that one is going to be longer than anything else we have. So that's exciting in terms of reducing the number of injections patients have to get. I will call your attention to Beovu. That was released in 2020, but unfortunately about 6 months in, we were starting to see some pretty bad side effects for patients. In about 1 in 200 patients, pretty devastating side effects. And so for the most part, that drug has fallen out of favor with a lot of retina specialists. And I'd say Avastin and Eylea are the workhorses right now, with Vabysmo starting to take some of the market share. A non-intravitreal injection that is out there, something called Susvimo, which is actually a device that has to be surgically implanted. It is filled up with Lucentis, and you can see the picture of the device there on the right-hand side of the screen. The device is surgically implanted, and the Lucentis slowly infuses into the vitreous cavity over 6 months. And then the exciting thing is it can be refilled in an in-office procedure. You don't have to go back to the operating room. And we were very excited when this came out. We thought this was going to be a long-term solution for patients. But as you can see on the slide there, it was just recently recalled in the past month because of some safety concerns. So the company has some work to do there to try to figure out how they can make this device safer, because it really can help a lot of patients, I think, if they can work out the safety issues. I referenced the laser therapy that I used when I was a fellow. That was known as photodynamic therapy, where you infuse a drug known as Visudyne intravenously, and then you combine that with a laser therapeutic. And that worked for about 2/3 of patients. So it was exciting that we had something at that point. But again, it wasn't nearly as robust as we wanted it to be. And for the most part, that's been supplanted by the injections. But every once in a while, we still use it as an adjunct therapeutic. So what's happening in trials right now? There's a longer acting anti-VEGF drug known as KSI 301 by Kodiak in phase 3 trials right now, but probably going to end up being similar to faricimab or Vabysmo, so maybe not quite as exciting as we wanted it to be. These next 2 drugs by Ocular Therapeutics and Graybugs are actually long-term depot delivery platforms that we think can last up to 6 months in basically half of those patients. And so we have some exciting things on the horizon from those 2 companies. I will note that Graybug did have some safety issues and has now changed their formulation, and hopefully they've solved those problems. And we'll see that in the next few months as their further trial results come out. There's 2 companies working on a gene therapy version of anti-VEGF. One is REGENXBIO and one is Adverum. Concept is the same, basically using gene therapy to create little factories in the eye, little factories that can either pump out Lucentis in the case of REGENXBIO or Eylea in the case of Adverum. And the thought is that if you can have a constant infusion of these drugs, then we're going to be able to help these patients have less injections over time. And both companies have shown a significant number of rescue injections that are needed in these patients. It hasn't solved the problem, but it's getting closer. And so pretty exciting stuff there. So in conclusion, it's a significant vision-threatening disease, both in this country and worldwide. I think it's an important thing for patients to understand that they can still maintain some functional vision even with this devastating disease. A lot of my patients, when I have to give them this diagnosis, are scared they're going to go completely blind, no vision, world of darkness type vision. And I always need to encourage them that that's not the case for the vast majority of patients. You can retain functional vision with this disease and do most activities of daily living with this disease. Yes, you lose reading vision and driving vision, and it can affect how you recognize faces. And these are devastating things, don't get me wrong, but dressing yourself, bathing yourself, and other activities of daily living can still be maintained. And I think that's an important thing for patients and family to hear. We have made significant advances over the past 15 years and have given patients some significant hope. And the things that are right on the horizon, I think are going to even further lower the impact on patients' visions and their quality of life. But we still have a long way to go. We still have a lot of work to do, and significant research and development is needed. And I can't say how much the Eye Foundation has done for us as clinicians and researchers. They've done so much for us, and it's a wonderful organization. And I encourage you all to support them any way that you can. And the work that they've done to support great researchers like my colleague, Dr. Ash, who's going to speak next, it is invaluable. And I thank them for allowing me to be part of this today. And I'm going to turn the floor over to my colleague, Dr. Ash.
Hi, thanks, Alex. That was really fantastic. We won't have much overlap. I've been deleting slides as you were talking, so hopefully we can keep the overlap to a minimum. I'm pretty excited to be here. I'm just joining the department. Actually, my official start date is in December 1st. So, but I will be coming in as the new director of research in the department. And so I'm very excited about this because we're 22 research faculty in the department. Most of them are fairly junior faculty. But they're really at the cutting edge of their research fields, and they're probably the most creative point in their career. So it's really, I think, exciting to be able to help establish a culture in the department that we can actually enable these faculty to actually do their best research and to move the field forward. In addition to that, I'm excited because there's a lot of fantastic partnerships in the University of Pittsburgh Ophthalmology with particularly the Eye and Ear Foundation. I think these partnerships with really bring together a nice environment where we can develop research projects. We can have opportunities to enable translational development. Real end goal of any scientific creation or invention is really to get it to the patients. And so there's usually a gap when you have scientific discovery and then translating that into a clinical therapy. There's a huge gap there. Actually, it's a Grand Canyon of gaps. And I think the infrastructure at the University of Pittsburgh is such that gap has got many bridges over it. And I think commercialization is the key to getting any new therapy development, to getting it in patients. So very excited to be here. Again, I'm looking forward to the partnership with the Eye and Ear Foundation and the Department of Ophthalmology in particular, because I really feel like this is a major selling point for being in the department. So one of the reasons I'm coming in. So just reiterate a little bit of what Alex was saying. This is kind of a fundus exam showing over here of a normal retina. This is probably this region here is what we're talking about, the macula, this right in through here. It looks a little bit darker in region. The central parts we will talk about in a moment is called the fovea. This is the part of the vision, part of the retina that we use for most of our vision. If you just give yourself a quick vision test, you can put your finger right over your pupil, stare at your fingertip about glasses distance from your eye. And I challenge you to try to read anything while you're doing that. You just don't have enough visual acuity from the peripheral retina to be able to read anything, to recognize faces. So really this macular region is really super critical for how we live and how we use vision. So showing here is an image of a retina that ophthalmologists would look at. This region in here is the macula, right? It's a very important part of the eye. This very dark center here is the fovea, the foveal pit. This is really high acuity vision. This is what we really need. We're talking about saving and preserving when we're talking about rescuing or developing therapies for macular degeneration. And as I said, you can cover up the very central pupil. You're blocking this image part of the retina, and the rest of the retina really doesn't have good visual acuity to allow you to read and recognize faces. You can still live a very productive life, but this is what we really use most of the time for our vision. So what does that look like if you look at histological sections of science? We often see tissues not as from the ophthalmology perspective, but we see it from a histological evidence. And if you look at this is what that very central part, the foveal pit, the macula actually goes from about here to about somewhere over here. This really has the highest densities of cells in the retina. This is the retinal tissue here. These in the lower level, the photoreceptors, these are the interretinal neurons, and these are ganglion cells, which send their axons into the optic nerve and into the brain. So that's the pathway is you have photoreceptors, they make connections with interretinal neurons, they make connections to ganglion cells, and then those send signals back into the rest of the brain. And as Alex was saying, the pigmented epithelial cell is a very important cell for the photoreceptors. These two cells, the photoreceptors and the RPE, actually work together. They really are a single unit. If you take them apart, then you can't have good vision. So we're talking about preserving the macula. We really also want to preserve the fovea, and we want to preserve the RPE, which is this pigmented layer, very thin layer right here. The rest of the pigmentation is the choroid. That's where the blood vessels are there. So, and as Alex said, you have the AMDs really can be divided up into various stages of disease. It's progressive. You have what's known as an early AMD. An ophthalmologist might be able to detect very small little focal spots in here. These are small drusen deposits that are there. But you know what, normally though, when they're there, patients may not even notice that those are affecting vision at all. As it becomes more of an intermediate AMD, the drusen might get larger, at least one large drusen deposit that you can see that's sitting between the photoreceptors and RPEs, usually under the RPE. And those deposits may affect some very small local regions of altered vision, but the rest of the macula is still functioning quite well. A lot of useful vision in early and intermediate AMD patients. When you get to advanced AMD, it's where you start getting things like non-neovascular, or talked about geographic atrophy. That's where you start losing the RPE cells die, the photoreceptor cells can die, and there's nothing there to detect light anymore. And you'll have a big hole in your vision, or stachoma in your vision. That is an advanced form of AMD, but it's not the blood vessels. So anti-VEGF therapies won't do any particular good for this patient. And then if you have the neovascular disease, we have the blood vessels growing into this space. Thus, when they're very leaky vessels, they actually can leak a lot of blood or fluid into the material out of the blood into the subretinal space, which are very toxic to those cells. And that actually can also lead to death, and increased inflammation and death of the RPE photoreceptors. The two advanced stages are really sort of an end stage disease. And then we need to talk about maybe developing therapies for these early stages, talk about these as separate diseases in a sense, because that's where the new therapy development, we actually have to focus on them differently. And at the moment, we have nothing really to treat early AMD patients or intermediate or even the GA patients. There are some things that are coming up, but we'll talk about that in a moment. But really, we have only the AREDS2 is what we have, and that as Alex is pointing out, is effective, but it has a fairly small effect. So when we look at geographic atrophy, really it's just simply there's no blood cells growing, but we lose the RPE, we lose the photoreceptors, right? And that leads to stachoma, or hole in the vision. That you just cannot, that central vision you've lost, and you just can't see through that anymore. The wet neovascular, another way to see it, you can see the blood vessels that are actually growing through Bruch's membrane. They're leaky, they leak blood into that space. That leads to accumulation of toxins and things, that iron and such, that could also lead to death of the photoreceptors and RPE, and again, loss of vision. So if we think about where the opportunities for therapy are, I mean, we need to, I personally am not looking at end stage disease as a researcher. I think our best target is to get patients when they have useful vision, but there are things on the horizon for these end stage diseases. Alex was talking about the anti-VEGF therapies. They're highly effective. They actually work to prevent the blood vessel growth and blood vessels from leaking. But you still have this slow progressive loss of the photoreceptors and RPE in those patients. So really, we really need to think about these early events as well. There are other inhibitors of angiogenesis, non-VEGF targets that are being developed. And those will be more reports of those coming up pretty soon. And as well as Alex mentioned, the gene therapies to deliver anti-VEGF. So we do have good therapies for wet AMD that are effective. We don't really have anything for geographic atrophy at the moment. What's going on in the laboratory for this is people are looking at stem cell replacement. There are clinical trials that are ongoing replacing the RPE cells with patient-derived stem cells and implanting those in and allowing those to occupy that space and resume that function. So if you have the RPE intact, you can then keep the photoreceptors functioning intact as well. There are other things that happen, such as prosthetic augmentation, as well, and optogenetics, that is involving a gene therapy. Sometimes these two things are combined, where you can make other neurons in the retina photosensitive, so you could replace the lost photoreceptors and RPE. So we don't really talk much about those, but those are other things that are involved in this late stage of disease. Really, though, I want to focus more on preserving this useful vision in early and intermediate AMD patients, and just so that we can develop therapies and stop and halt the progression into these late stages or end stages disease. So to develop those therapies, we need to understand the risk factors for AMD. And genetics is a pretty strong component. These large GWAS studies, or genome-wide association studies, have looked at thousands, tens of thousands of patients, and have looked at patients who are affected by AMD who are not, and they've tried to identify DNA sequences that correlate with disease that are found more frequently in diseased patients, but not in healthy patients. And to date, I think many people in the field feel like we've almost saturated the analysis right now, but scientists have identified 32 genes and actually 52 different mutations in 32 genes, which are strongly associated with developing age-related macular degeneration. And they're not on just one chromosome, they're spread out on all 22 autosomal chromosomes. So we really have really complex genetics involved here. Age is another major risk factor. It's probably a bigger risk factor than genetics in some sense. Most of it happens, we diagnose it in patients over 65, but obviously as you get older, then the incidence increases. So age is a major factor, but you can detect early AMD signs in patients in 50s and 60s as well. Believe it or not, behavior is probably, I'll show you in a moment, is a major risk factor, and things that we can really change. Smoking, alcohol consumption, obesity, high fat diets, high glycemic index diets, and these we can modify these things that we can maybe reduce that risk. But having these components in your lifestyle will increase risk for developing disease. And now we're beginning to understand exposure. So the microbiome, these are the bacterial flora that's in our GI tract. Those are thought, the research is showing that those are thought to control even onset or maybe progression of AMD and maybe a risk factor for AMD. There's a lot of work going on to that right now. It's just kind of an exciting new area that I don't really have anything more to say about that, but just exposure for things that are environment or in our GI tract can also lead to disease. And so we need to develop the therapy, we need to understand how some of these things interact with each other, right? And so it's not like you have a gene that's highly likely, is highly more frequently in patients with AMD than in normal patients or patients who don't have AMD. But even if you have that mutation, it doesn't guarantee you're going to get AMD. So we don't do genetic testing that right now because of that, but those genes give you increased risk. And so if you think about how the genes or the changes with age or the change in behavior or exposure, how those affect the cell and cell biology, how they combine with each other to affect cell biology, then we can design therapies to target those effects. We can't really do anything about aging because we all want to live longer. So but we can understand what happens in age, the changes in the cell. If we can target those specifically, then we can possibly correct that. But the way these risk factors interact is quite interesting. So one of the things that we see that's probably first happening very early in disease is we have abnormal metabolism, and that's the way cells generate energy, when they take up glucose or take up other nutrients from the blood, and how they convert that into chemicals that they then use for energy and building blocks for parts of the cell. For example, the photoreceptors are really highly biosynthetic. They make a lot of proteins and a lot of lipids every day, to make more membranes. And the opposite is true for the RPE. They actually take up and digest and remove a lot of lipids and proteins on a daily basis. And both of those cell types have very high levels of metabolism. And if you do things to alter those metabolic rates, both of those cells become under stress and they then lose some cellular function. For example, photoreceptors are less responsive to light. The RPE is actually able to process less of those lipid and proteins that they take up. And that's where you start getting drusen deposits. Both metabolism and cellular function are also affected by increased oxidative damage and oxidative stress. That's where smoking, alcohol, and high-fat diets come into play, because those all can lead to increased oxidative stress, which can alter metabolism and lead to loss of function. Once you start getting these increased oxidative damage, and you get this drusen, then you deposits, then you can start getting increased local inflammation. And that's where a lot of the genetics can also take place. So a lot of the genes that we're finding increased risk actually are leading, many of them are in an inflammatory process cascade that's known as complement cascade. And as Alex mentioned, there are many drug targets trying to get at the complement cascade to actually reduce that inflammatory event. But these things lead from one to the other, and then they feed back on each other. And ultimately, you get all of these going, you can actually lead to cell death and loss of vision. And once cells start dying, then that actually can target neighboring cells. And so that's one of the phenomena for AMD. It can start out as small regions, but then it can actually start beginning to spread. GA may start in a small region, but eventually it will begin to spread and occupy more area of the macula. So what we need to think about is how can we target metabolism? How can we target this changes that we see with age? So, or with even some with behavior. So can we restore metabolism? And part of the work that's going on in my lab and other labs is we're actually looking at developing drug therapies or gene therapies to actually maintain high levels of metabolism of the cell. And these are actually in model systems that were studied are pretty effective at doing that. And I hope one day that we'll get some of these into clinical trials. The other target is looking at how do we maintain cellular function. So the phagocytic function of an RPE, or its ability to digest those proteins and clear them out of the eye and get them into the bloodstream, is important. And so we need to understand what's going on there to maintain that function. And that's where I think some of the things with obesity and high fat diets and smoking take a role as well, because they're disrupting lipid metabolism quite a bit. And this is part of the function of RPE, and we really need to maintain that. So changes in behavior or drugs that can actually promote appropriate lipid metabolism are likely to maintain that function. So that's something that's actively being investigated. Decrease oxidative stress. So that's obvious one. Decrease smoking, alcohol, obesity. That take your AREDS vitamins. Those are really important ways to decrease oxidative stress. But really, that's just one. You might need to target this disease at multiple levels and be able to develop therapy. So we might need to restore metabolism as well as decrease oxidative stress. It may take multiple therapies or polypharma to target this disease appropriately. Increased inflammation. So this is actually where if you look at the genetics, many of the genes involved are in complement cascade, which is part of the immune system, and they all put you at increased risk for increased inflammation and cell injury. And so several now companies are actually looking at developing complement cascade inhibitors. But there are, I think in the laboratory, we're beginning to look at that a little differently. I think we can actually develop some long-term sort of gene therapies that actually can target this complement cascade, and they either correct the genes or not, or add in other additional inhibitors of that complement cascade as protein therapies, so that we can more tightly regulate that. As Alex mentioned, some of these complement inhibitors are leading to other problems, so we need to understand what those other problems are. And of course, if we target one or more of these pathways, then what we've done is we can prevent loss of cells and loss of vision. And so that's really kind of what we would like to do, is to block that loss of vision. And part of that is we're looking at some gene therapies, I'll explain that in a moment, that actually increase the cell's resistant to injury from oxidative stress or altered metabolism. And so we're looking at neuroprotective strategies to target that. So here's what's going on in my lab at the moment. So we're looking at drugs that can alter metabolism. Fortunately, though, there are a number of, for years, people have been studying this for other diseases such as diabetes, or people looking at G protein coupled receptor signaling, have noted that when they activate some of these receptors and these pathways with drugs, they can stimulate changes in metabolism. And so we've been studying these drugs. Some of them are FDA approved, to see how they can alter the course of AMD or alter the course of cellular damage to the photoreceptors of the RPE. And one of the drugs that we have done the most work on is called metformin. It's actually given to most type 2 diabetics to control blood sugar. It works because it promotes glucose uptake and metabolism. So it actually increases metabolic rate in cells. And we've actually demonstrated that in the retina, we can put metformin on, and the retinal RPE and the photoreceptors will increase their metabolic rate. And they actually are more resistant to inherited mutations as well as increased oxidative stress. So we looked at patients who might already be taking metformin, and we, in a study, a retrospective study, of about 7,000 patients, there's about a 30% reduction in risk in developing AMD for patients who are taking metformin. So there's signal in the laboratory and this can reverse some of that, but there's also a signal in patient databases that this can be effective. Fortunately, other groups have also repeated those studies in larger cohorts, 15,000 or 20,000 patients, and they found the same protective signal that we did. The proteins therapies that we've been developing, including a protein called LIF, or leukemia inhibitory factor, and it's a closely related molecule called oncostatin M. These are proteins that we've made in the laboratory, and we can inject them into eyes, and they can lead to increased resistance to cell injury or cytotoxic damage in the photoreceptors and the RPE. And so this is, it's kind of like the anti-VEGF therapies. You have to have repeated injections. So we've been actually turning those into gene therapies, where we engineer those proteins. They could express them into and package them into AAV vectors, where we can deliver them in vivo for long-term or sustained expression. So we've been turning these protein therapies into gene therapies. And we've also been developing some gene therapies that can regulate metabolism and increase metabolic activity. So there are a lot of things on the chalkboard or the whiteboard these days that we can actually develop therapies also to control the complement cascade. One of the things with gene therapies that you have to have is a way to regulate the therapy. So if you put in gene therapy, it's more or less permanent. And so you get the virus in, it takes taken up by cells, and it stays in the cell for as far as we know, as long as the cell stays alive. If you have a negative outcome, you're kind of stuck with that. So what we're looking at ways that we could regulate the gene therapy. And so what we've engineered here is a very synthetic gene where we have our protective factor, in this case LIF, and we put it onto a protein domain tagged onto it that will destabilize the protein and prevent it from being accumulating. So we package this into a virus, we inject it into the eye, the protein gets expressed, but it doesn't survive long enough, so it doesn't have a lot of accumulation. The protein actually gets made and is degraded rapidly. So there's really no biological effect of that protein. However, we can give a second drug, in this case an antibiotic called trimethoprim, and that can cross the blood-retinal barrier and can enter the eye, and that would actually lead to stability of that protein. It stabilizes the protein, prevents it from being degraded, and then we can get it cleaved off, and we can actually wind up with our protective factor being released. And this actually, we've shown that we can give a little bit of trimethoprim, we get a little bit of our LIF expressed. If we get more trimethoprim, we get more LIF expressed. So we can regulate the level of expression. And then also, if we remove the trimethoprim, all of the expression goes away. So it's a reversible gene therapy. So we're actually now trying to develop this and put it into larger animal models so that we can study how effective this might be and lead to therapies in patients. A little bit more about the genetics. So down at the bottom showing each chromosome in the human genome. So chromosome 1, chromosome 2, chromosome 3, all the way to 22, and then the X and Y chromosomes. And each of these bars are DNA changes that have been looked at, identified in patients that have AMD more so than in patients who don't. And if they cross this red line here, then they were deemed to be statistically significant and more strongly associated with disease. And some of them that cross the second line here are really highly associated with disease. And so there are 32 of these genes that are showing up there. But it's not, as I mentioned before, it's not like if you get the gene, you're going to get AMD, right? But many of these genes are involved in the complement cascade. It's complement factor H, complement factor 1, complement factor 9, and there's a few more in here that we can identify. It's complement factor 3 over here. So if we can understand, some of these genetics and how they work together with behavior, then we might actually have better therapies. So if, as I mentioned before, you can have these mutations in complement factor H, but not have AMD, which is great news. How is the behavior interacting with that mutation that's allowing the disease progression? And can we alter that cellular function of behavior so that we can keep everybody who has that mutation without getting disease, right? So there's been a study that's come out of the IRIS consortium. It's a really large group of scientists that have been looking at this initially, and they put patients into different bins. So all those mutations are on different chromosomes. So it's possible that patients have multiple mutations associated with AMD. And the more mutations you have for AMD, then the higher your genetic risk, right? And the fewer mutations you have, the lower your genetic risk. In fact, there are even protective sequences that will cancel out a high risk mutation. So those patients that have protective alleles or low risk genetic risk are here. Those at medium risk are here, and then those at high risk are here. And if you look at this group, they then divided those into three different categories. Those who have favorable lifestyle, those who have an intermediate lifestyle, which means they have some good behavior, some behavior that's a little high risk, and those that have really exceptionally high risk behavior. And what I want to highlight here is that if you have really favorable lifestyle, don't smoke, watch alcohol consumption is moderate, those kinds of things, then and you have low genetic risk, your likelihood of getting AMD is actually pretty low. It's the lowest. But even just increasing risky behavior along with that without any genetic risk can increase your risk of getting AMD about threefold. So really you can three times likely to get AMD just by doing some of these behavioral modifications. But likewise, if you have high genetic risk, right, you're 10 to 20, maybe 30 times more likely than a low genetic risk patient for getting AMD overall. But if you have increased behavioral risks on top of that genetic risk, you can further increase your risk by another fourfold. So you're 4 times more likely to get AMD in all cases, independent of genetic risk, just by having some of these high risk behaviors. And so those in the lab, we can develop all the therapies we want, but there's some things that we really need to talk about, and that's how to lower risk through behavioral changes. And part of that is avoiding high fat, high glycemic index diets. Don't smoke. If you stop smoking, if you have smoked, the ARES2 supplements help as well. And moderate alcohol consumption and regular exercise, I think, helps as well. There's some evidence for that. Things that the microbiome may be important for that. We'll learn more about that in the coming years. But changing behavior actually can affect the risk of getting this disease by 3 to 4-fold. And that's a pretty significant shift. And that's something that we all can work on doing. So I think with that, I will stop and we have you start taking some questions.
John, thank you so much. And we have a lot of questions. So let me start. So, we've talked about the risk factors, okay? And we got a question immediately. So is it any alcohol consumption that is problematic, or is it moderate to hardcore alcohol consumption that's problematic?
This is just being studied right now. These questions aren't really answered. I think the field, the binge drinking is the worst, right? Okay. So hardcore high levels of alcohol consumption are considered the worst. And Alex certainly chime in on this too. But I see that as the worst part of it, and sort of daily consumption is probably in the median of that, in the middle of that, and then just very infrequent is probably very low risk.
Sounds
yeah, I don't think I have much to offer differently than that. I tell patients, every choice we make in life has risks and benefits. And if a glass of wine with your spouse brings you great joy in the evening, don't feel like you need to cut that out. It's the benefits outweigh the risk in that scenario. Now, should you go drinking in Southside for a binge drink? Probably not, right?
Yes. Okay, got the picture. So on that note, if you are engaged in kind of these riskier behaviors, should you have genetic testing?
It's not offered. It's not offered. It's not possible to get genetic testing through the clinic, official genetic testing for AMD risk factors.
Okay.
Because it can't affect therapy at all, right? I mean,
I was just going to chime in. I have had patients come in with 23andMe and some of the other commercially available genetic testing that's out there, and they're panicky and they're saying, "Oh my God, I'm going to get macular degeneration," and I need to kind of rein them in a little bit, as Dr. Ash was explaining, that just because you have a genetic risk factor for it doesn't mean you're going to get the disease. Genetics is way more complex than we fully understand, about expression and penetrance and all these other things about genetics that we don't fully quite get yet. Having the gene alone, it doesn't tell us anything yet. And I'm also pragmatic about it. To Dr. Ash's point, we can't fix anything yet. And you get the genetic testing, And what are you going to do with that other than worry a bit? And then even more on the scary side of it, what is an insurance company going to do with it? Life insurance, health insurance, disability insurance. How are they going to view those things when that gets into your public record? How will they view those things? So I look at it from that standpoint. Until we can modify it, I don't see the real value in testing for it yet.
So great points. Thank you. So on that note, so say you were someone, and this question popped up, say you were someone that has an issue with inflammation, systemic inflammation. No signs yet of AMD, but could something like that, like a lupus or an arthritis, give you a greater potential for getting AMD?
I don't know. I'm gonna let Dr. Ash reply if he's seen anything in the literature about that. I have not, but Dr. Ash would know that better than I would.
There are other eye diseases that you could contribute to. That's not specifically AMD. So uveitis is one of them, right? That is a major risk factor for that. And then there are autoimmune retinopathies that you can actually lose the photoreceptors because you have you start developing antibodies to that. So there are other risk factors, although not necessarily AMD. If you have those, definitely, I think it's important to see an ophthalmologist on a regular basis.
Absolutely.
To be screened and to be monitored. I mean, I think that's very important advice. And also, if you do think you have high risk genetics, also it's important to see an ophthalmologist on a regular basis, just to monitor that progression. If you have early, small drusen, early AMD, keep track of it, right? Watch it. Most patients will tend to stay very slow. 90% of the patients with AMD, the statistics I know, like I've said, know something I've never seen a patient, right? Not 90% have this sort of early and intermediate AMD. They develop drusen, but they may or may not progress further. The 10% develop these sort of late stage disease, but they're the ones who are really dramatically losing vision, right? So that's why early focus has been on developing therapies for those patients, because that's really where the substantial vision loss has been, right? And now we're thinking, okay, we've gotten some progress there. Let's back that up and let's prevent them from going into those advanced stages.
So another question popped up. Can you discuss oxidative stress? I hope I'm pronouncing that correctly.
That's correct. So there is a theory with aging that we have increased oxidative damage, or we have decreased resistance to oxidative stress, right? And so oxidative stress is defined by, I don't want to get into chemistry here, but there's a free radical biology, right? Where you actually have an extra electron in chemical molecules, and that will attack other proteins or DNA or RNA, and that will lead to changes in the cell. And those attacks accumulate, right? They're cumulative, right? Normally, cells have great repair mechanisms to repair DNA or to repair proteins or turn them over. And as we age, those repair mechanisms decrease, right? And so we have less resistance to oxidative stress, right? And that's one of the ideas of aging, is that we just have accumulated damage to oxidative stress. And so part of that leads to changes in a technical term, mitochondria, which is part of our cells that drives energy production. And the DNA damage and mitochondrial damage is one of the things that leads the cells to lose function and to start dying. So oxidative stress, the AREDS vitamins are fantastic. Most of this in there can reduce oxidative stress, oxidative damage. So that's one of the reasons they're there.
And then, metformin. Let's talk about that, because metformin is being looked at for a lot of things. At Pitt's Winter Academy several years ago, there was a discussion by a researcher on its anti-aging properties, but then also metformin is used by OBGYNs for polycystic ovarian syndrome. So this is all very interesting. Is this just a miracle drug we should all be taking?
No, it's not. So metformin actually does what we want it to do, in the sense that it can activate metabolism in a cell, right? And that's where we're getting these therapeutic benefits, and certainly for aging, and certainly for what we're seeing for retinal degeneration. It's also being used for muscle atrophy, but it causes cells to use a lot of glucose, but that can lead to things like if you're eating a lot of high sugar diet material, you're going to generate a lot of lactate, right? And that actually can lead to kidney damage, right? So it's not ideal, but it tells us this is the right kind of pathway to get to, right? So if you're taking it, I strongly recommend you watch what you're eating in terms of glucose uptake or sugar uptake, right? Be careful with your diet, particularly when you're taking metformin, because I think that's an important part for that. It's not a perfect drug, no.
But it's sounding like it's on that path. No, I'm just joking, but there's so many uses for it. So this is a clinical question. Dr. Anetakis, can you get AMD in both eyes? And then with that, can you describe what the injections are like?
Yeah, absolutely. So in terms of macular degeneration, by definition, it almost always is in both eyes. It may not be symmetric. You may have more advanced disease in one eye than the other, but almost always is in both eyes. And if I see a patient with a perfectly normal macula and macular degeneration in the other eye, I have to start questioning my diagnosis and start thinking for masqueraders and things that it might other be. But if it's not in both eyes, it really raises red flags that maybe the diagnosis is wrong. In terms of the injections, every patient is always worried when I start approaching the injection need and what that means and what the process is going to be like. And I'm able to reassure them that in 98% of my patients, I'm able to make it completely pain-free. And in the other 2%, we have to do a little bit more advanced numbing methodologies. That numbing method has a little bit of pain to it, but then the actual injection itself has zero pain to it. So we're able to numb the patient completely well. With a really tiny needle, the methods are really pretty much pain-free at this point. It's not completely risk-free. There are risk of infections and bleeding and retinal detachment, things like that. And so we don't take it lightly, but from the pain standpoint, I'm able to reassure patients of that.
That's great. So can you discuss the microbiome more in depth? And are there any big studies going on within the department?
So I can speak to that briefly. I won't go into depth because I don't know his research as well as I'd like to, but there's a great researcher here in the department, Anthony St. Leger, and that is his field is microbiome. And he specifically is looking at the microbiome and how that affects macular degeneration. I'm part of a group here known as UPMC Enterprises as well that helps fund research for doctors in the Department of Ophthalmology as well as throughout the system. And we have funded some of his early research in that area. And so I have a glimpse into what he's been doing, but I will not sit here and tell you that I'm an expert on it. But I do know that he's made some interesting findings to date, some of which is confidential. So I need to be a little bit cautious of what I say.
Yeah, he's working with another faculty in the department, Rob Shanks, and they're the team that they're putting together is actually really beginning to consider that. Mostly what people that I know of across the country they're looking at is they're actually trying to, like we do with genetic studies, to find out what genes are associated. They're looking at using genetics to look at the genes or the genetics of the microbiome to find out what microbiome species are associated with protection, not necessarily cause of disease, but in more frequent in patients who don't have disease, right? But also maybe increase risk, but it's looking at the bacteria itself, not looking at the patient so much.
Gotcha. So on that note, with research, are we looking at, this question popped up and it's a good one, are we looking at increased clinical trials and research trials for the department over the next few years?
That's our goal. I think so. Yeah. I think as we start thinking about, there's an FDA approval process for these things, right? And so clinical trials are they have to be funded by somebody, right? So they have to be sponsored. So you have to have the intellectual property there, right? You otherwise the company would never touch it, right? A very famous retinal specialist, I won't mention his name, but he was very prominent in the field, said he wasted 4 years of his life because he was working on a drug to affect rhodopsin activity. And he published everything before he sought to get any intellectual property on it. And he said, I wasted that time because, I moved the field forward, but unfortunately, I didn't help any patients, right? It could have. Had I protected that information, a company would have taken it up and would have pursued that in a clinical trial, right? So our objective is to seek intellectual property on as much as we can and protect it, research discoveries, so that we can then get companies interested in investing in that and funding, or even developing our own startup companies. I think the UMPC Enterprises is an arm of that, developing ways that we can develop trials around these new discoveries. So absolutely, that's a goal.
And I'll add, with the arrival of Dr. Jose Sell as our chair in 2016, that was one of his main goals, was to increase the retina department, not just in size, but in quality of researchers. And he's done a great job bringing in clinician scientists who have really expanded our research profile. We had a great department before, and he's making it even better.
Absolutely, on both, aspects. So we have one last question, and it's a perfect one as I look at my iPhone to see what time it is. How does light from a smartphone, does it potentially affect your eyes?
So fortunately for as humans, so there's the blue light phenomenon, right? That's affecting, and blue light can lead to oxidative damage to certain molecules in our cells, particularly DNA. And so there is some ideas about that, but we're pretty well protected from that, from macular degeneration, because we have these called macular pigments, the zeaxanthine that's in the AREDS2 formula. They actually absorb most of that, or a lot of it.
Okay.
And so the blue light will do things like mess up your circadian rhythm, right? Which won't help your inflammation or chronic stress, right? But it's not going to be a direct toxin, I think, as much as we worry about from the smartphone, right? Sun exposure, there's no scientific evidence for that, but Pittsburgh, probably not a problem, but here in Florida, it's probably a major problem.
Yeah.
Right?
Well, and as I tell my patients on the sun exposure side of it, it definitely is linked to cataracts. It's definitely linked to conjunctival damage and even corneal damage. And so for those reasons alone, you should be protecting from UV radiation to the eyes from that standpoint. And then if it is going to benefit the retina, then you just have that nice little side benefit.
Yeah.
I think on the blue light side of it, as I tell my macular degeneration patients, it's like closing the barn door after the horse is gone. It kind of doesn't matter at this point.
Right.
But where I at least have thoughts about it and questions about intellectual curiosity is teenagers and these people now that are starting, have grown up on these phones. What are they going to look like 50 years from now after 50 years of screens? I don't know that we have that answer, but it's an interesting thought process to kind of think through.
Well, on that note, we are at the end of our hour. If we did not get to someone's question, we will get an answer out to you via email. But I wanted to thank both of you so much. Dr. Ash, welcome to Pittsburgh. We're so excited to have you here. Dr. Anetakis, as always, thank you so much. And join the Eye and Ear Foundation in 2 weeks for our next webinar, which will be from the Department of Otolaryngology. Thank you and have a good day.